Good afternoon, everyone, and thank you for joining us today on behalf of the National Collaborating Center for Methods and Tools. My name is Jennifer Yost, and I'm a knowledge broker here at NCCMT. And today we have our Spotlight series featuring the Applicability and Transferability Tool. Just a few housekeeping issues. We will be having a question and answer period at the end of the webinar session, towards the end, likely about 2 o'clock-ish. And so please post any comments or questions into the Q&A, and I'll ask those of our presenters towards the end of the webinar. Please feel free to post any questions and comments during the actual webinar as they might come up for you. And also, if you have any connection issues, we recommend using a wired internet connection, and there is a 24/7 helpline to WebEx, which we have also posted in the chat. After today, we will be posting the PowerPoint presentation in both English and French, and we will be posting the audio recording to our SlideShare and our YouTube channels. We'll post a link to those directly into the chat momentarily. So just to get a sense of who has joined us today, we have a polling question here. So we're wondering how many of you are watching today's session or joining today's session just yourself or in a group. We do try and get a sense of who is joining us. So as I see that many people are participating in our polling question, and thank you very much. It seems that the majority of people are joining just themselves, but we do have people joining in some groups. So thank you very much to all of you who have responded. So this is our webinar within our series called the Spotlights on Methods and Tools, which is a series in which we feature tools and methods that have been collected through our Registry of Methods and Tools at the National Collaborating Center for Methods and Tools. So this is our 21st episode, which is very exciting for us. And as I mentioned today, we will be talking about the Applicability and Transferability Tool. And we will be posting a link directly to the tool in case you wanted to view it during the webinar in the chat momentarily. So we have another question for you, again, just trying to get a sense of who has joined us today. So wondering where are people from? So are you from within Canada, or are you from outside of Canada? So we do have someone joining us from outside of Canada. Thank you very much. And the majority of participants responding to our polling question are from Ontario, from British Columbia, and from Manitoba. So thank you all for those of you who have taken time during your busy day today to join us for this webinar. So a bit about the National Collaborating Center for Methods and Tools. For those of you who may not be familiar with us, we are part of the National Collaborating Center for Public Health Programs, which is dispersed throughout the country with 6 national collaborating centers. Here at the National Collaborating Center for Methods and Tools, or NCCMT, we are located at McMaster University in Hamilton, Ontario. While 4 of the National Collaborating Centers support use of research evidence in specific public health content areas, such as environmental health or infectious diseases, here at NCCMT and also within NCC Healthy Public Policy, we work across areas. And our focus at the National Collaborating Center for Methods and Tools is to improve access to and the use of methods and tools to support moving research evidence into public health policy and program and practice decisions in Canada. So another polling question, wondering what sector are you from? So public health practitioner, health practitioner, education, research, provincial, territorial, government ministry, municipality, policy analyst, or other. So thank you to those of you who are responding. So we have the majority of our attendees today are public health practitioners. We have a few in provincial or territorial positions and a few in other types of positions. So we are very happy today on behalf of NCCMT to welcome a few different presenters. So our first presenter will be Donna Saliska, who is a Senior Knowledge Translation Advisor and the original Scientific Director of the National Collaborating Center for Methods and Tools here at McMaster University. And then we have a few presenters from the Sudbury and District Health Unit who will be speaking about how they have used the Applicability and Transferability Tool in their work at Sudbury and District Health. And so we have Melanie Hood, who is a health promoter with the Health Promotion Division in the Sudbury and District Health Unit. We have Stephanie Bale, who's also a health promoter at the Sudbury and District Health Unit. Shannon Dowdell-Smith, who's a manager in control of infectious diseases, vaccine preventable disease, and tuberculosis in the Clinical and Family Services Division at Sudbury and District Health Unit. And so at this time, it is my pleasure to turn over the presentation, our webinar today, to Dr. Donna Saliska, who will give us a brief overview of the Applicability and Transferability Tool, and then we will hear from our colleagues at Sudbury and District Health Unit on how they've used that tool to help inform their practices and programs at their health unit.
Thanks, Jenny. It's Donna here. I'm just going to give a bit of the background about the Applicability and Transferability Tool. And this tool was developed in order to help people make decisions, particularly across competing possible programs, what program might be the most useful to put in place, but also to think about criteria for stopping programs if you have some evidence that the program is not being as effective as you had hoped. So, how familiar are you with the A&T tool? Not familiar, you've heard of it, or you've used the A&T tool?
So from the polling questions, it's Jenny here again. It seems like that most people are actually not familiar with the tool. We have a few participants who've actually heard of the A&T tool and a few that have actually used the tool, so that's really great. Thank you to all of you for your responses today.
So knowing that public health groups do not have all the resources to put in all programs that they might want to or that the public might want to experience, it was trying to develop a structured way to look at different kinds of programs after you've looked at the evidence. So if you know the wheel from NCCMT, it's the adapt phase that we're looking at. So at this point, you will have defined the question, done efficient and systematic search, found some information about a particular intervention, done the critical appraisal, and made a decision about which information you're going to pay attention to, so you end up with some possible recommendations. From the possible recommendations, you need to look at, could this intervention work in our community? So how do we take the results of some research and think about how useful it would be and could it work in our own community? So that's the adapt phase. So if you're familiar with this model, it's taking the research evidence and trying to bring in evidence from all of these other areas. So the community context, community preferences, population preferences, what resources you have, and what the expertise is. So we've always maintained that evidence-informed decision-making is not about just the research, and you have to consider other aspects besides just what the research says. But the adapt piece is taking into account all of these other factors. So could this research possibly work within our context? I think they can hear the, yeah. Can it show me this? Okay, sorry. So the A&T tool was developed from a literature review that was initially done up to 2006 and updated in 2007 to see if we could come up with some actual criteria for how to decide if a program should be put in place or should be stopped. The references there for the actual paper that you can find on the NCCMT website that includes the literature review. One of the key references in that paper is by Wang and colleagues from 2006, where they had identified some of the criteria that we then went on to develop questions that related to those criteria and tried to get that all in a one-page questions with some information about how to actually use it. So in 2011, that tool about adapting a program or an intervention, we had people responding saying it would be useful to have the criteria, the questions rewritten so that they could look at stopping an existing intervention. So there is a type A and a type B. Both are on our website. Applicability refers to, is it possible, could this intervention we found in the literature, where it was effective in the literature, actually work for us? So thinking about things like the feasibility of the implementation, the plausibility, could we have the same kind of outcomes, the acceptability to the local community and the local political process. The transferability, the factors are there. There are criteria for each of these aspects. Transferability is more like, will it work? So could you expect similar results as the research is telling us in terms of is the population similar enough? Is the extent of the problem similar enough to the way it was studied in the original research? So would it be possible? Could you expect the same kinds of outcomes in the local setting? And that's looking at the magnitude of the health issue, the possibility for reach, the possibility for cost effectiveness, what will it cost in your area, and how the target population is similar or differs from the research. So there are a couple of different ways the tool has been used, and you'll hear about one of those from Sudbury. But as we said, it's after you've gone through fairly extensively the other aspects of the wheel, the defining the question, search, critical appraisal, and synthesizing, so you're coming up with some recommendations. The process involves getting a broad but manageable group of stakeholders who could have an informed discussion about the criteria. Sometimes people have said that for a particular intervention, some of the criteria are not important, so they can be not applicable, taken out of the process. Sometimes people feel that for a particular intervention, some of the criteria should be ranked higher than others. So as a group, you can make those decisions and then decide about scoring. The most effective way that I've seen it used is that people do the scores individually, so they come prepared to a discussion with their own scores, but then they reach consensus about the criteria and the overall decision at the end.
Great, so thank you, Donna, for that wonderful overview. And we are now going to turn over our presentation, our webinar today, to our colleagues at the Sudbury and District Health Unit.
Hi, Jenny. It's Shannon here with Stephanie and Melanie. And I'm going to start our little section. I just have to figure out the technology. Forgive me. Oh, we're good. Okay. So I'm just going to introduce a little bit how we got to using the tool. First and foremost, I think it's 3 years now, ladies, we started EPWIC. Maybe 3.5 years ago, we started our EPWIC group, which is our evidence-informed practice working group, which is made up of 3 specialists, and I think there's probably roughly 10 or 12 health promoters in the group, our librarian and an epi and a data analyst. And we meet monthly to discuss any evidence needs for programming, and that's sort of where this whole practice-based question discussion came from. We had kind of wanted to use Peel's model for practice-based questions, and so we were using some of their questions that they had answered on their website, and we came up with evergreen document which we populate every year, and we call it our practice-based questions list. And we ask every team within every program within our health unit to come up with their top research gaps or evidence needs in their programs and come up with a research question based on those needs and gaps. And the document, the list itself, is evergreen in that it's always sort of changing. If the ministry comes up with new guidelines, that may toss one of our ideas out the window. Or if community need changes, of course, taking into consideration all those spheres of evidence that Donna just described briefly, needs might change. So the list changes, but in this particular year, we did successfully complete 3 or 4 different practice-based questions, and we're going to talk today about 2 of them, postnatal support and academic detailing. So the first one, the postnatal support, this came out of the question on the list is, are postnatal classes an effective method of promoting child and family health, and if so, how can they be effectively implemented? Just before I hand it over to Stephanie to talk about how we use the Applicability and Transferability Tool, we had postnatal classes in our health unit in the past. And then those were sort of sunsetted because they weren't considered effective in when they were evaluated. But then the community told us that they needed postnatal classes. So we then used this as a research question, a practice-based question rather, to try and figure out if it's something that we needed to re-implement in the programming. So I'll pass it over to Stephanie Bale, and she can tell you a bit about how we went about that.
Thank you, Shannon. So Shannon gave you a really good introduction of why we chose the topic of postnatal classes. So just due to limited enrollment, we wanted to consider offering them again because anecdotally we had heard throughout our community, in addition to other health units have had success with the implementation of the classes. And there was also an identified gap in terms of that between birth and 6 weeks, that vulnerable time for new parents to receive some support, any services, referrals to different supportive services. So we developed a subgroup of our evidence-informed practice working group in addition to some programming staff. So that included our family health team and our Healthy Babies, Healthy Children staff were brought together to conduct the search. So we did a rapid review of evidence, which I believe took approximately 6 to 8 months or so with competing priorities. So we reviewed the evidence, reviewed the applicability of the evidence, we appraised the quality, and we summarized everything into a fairly concise report and developed some recommendations based on that evidence. So just a quick overview, the evidence did show that there was a benefit to offering postnatal classes, and it also offers some suggestions on successful implementation. So it was found that these postnatal classes do increase parental knowledge, they help with infant-parent issues, lack of sleep, and should be available to all new parents who wish to access them. In addition to some substantial evidence to support the benefits and suggestions for implementation, our working group recommended further investigations prior to its implementation. So this just included, oh, thank you, Shannon. This just included similar services offered in the community, possible partner organizations interested in offering or developing the classes. So that's just a quick overview of what came out of our rapid review. I'll now hand it over to Melanie just to talk a little bit of our academic detailing piece.
All right, thanks, Steph. For academic detailing, the situation was a little bit different because we did not have we didn't have anything like it within our health unit. So before I start, I'll just give you a little bit of a background for those who are not sure what academic detailing actually is. So it's essentially a type of continuing medical education. It's based on the model of pharmaceutical reps. However, in this case, a trained academic detailer would go in to visit physicians or other clinicians to provide evidence-based information And the purpose would be essentially to build relationships so that information can be then transmitted to clinicians in an easy fashion, and it would be tailored to the needs of those individual clinicians. So we had heard that there were a few programs throughout the country, and we want to kind of know how academic detailing was being used in Canada, but also in other countries. So we want to look at the different practice settings in which it was being delivered, who the academic detailers were. So in some cases it was physicians or pharmacists, nurses, or members of the public. Also in the methods of delivery. So was it better to do it one-on-one or within a group setting? And also we want to look at the types of behaviors that they address. Was it kind of health promotion type, or was it more of a clinical based behaviors? The second part was that we want to know if public health could use academic detailing in a way to change or influence clinician behavior. Okay. So the findings of our rapid review, and like Stephanie said, it took about, I guess, 6 months to do. In this case, because we didn't have any dedicated staff assigned to academic detailing, it was based on volunteers and anyone who had somewhat of an interest in the process. So we did find that academic detailing was an effective communication tool. So our next question was to find out whether the Sudbury and District Health Unit should be using academic detailing as a strategy. This led us to ask to ask ourselves if staff actually believe that we could use academic detailing to share evidence and best practices. So we really wanted to speak with those who are working frontline, especially with some of our clinical staff who already had existing relationships with community clinicians, but also to ask staff in a variety of different divisions to see whether they thought that this was an area we should venture into, or whether, our recommendations may not be applicable.
Perfect. So now that you have a bit of a background of the results of our rapid reviews, we're going to talk a little bit about our use of NCCMT'S A&T Tool. So in terms of the postnatal classes, what we did was we shared our report findings with the managers who had expressed an interest in reevaluating postnatal classes, in addition to some additional staff members and members of the research group itself. So we shared the report. We also shared the A&T tool to have a quick look at a few of the questions that we would be posing so that they could prepare for it and be a little bit more informed of the process of the meeting. So in terms of the type of questions we asked, we looked at, the A&T tool looks at social acceptability. Was there an interest or need for the intervention? We looked at available essential resources. So what do we currently have available locally in order to implement, and do we have adequate training available, and are there any health benefits to this? In addition to that, we had organizational expertise and capacity. Does this intervention fit with its mission, local priorities, and is our organization motivated to do this? And then in terms of transferability, we looked at local data, research evidence around the magnitude of the health issue, and does the need exist for a postnatal program, and are there any programs currently in existence that we could potentially partner with or leverage? And the magnitude of the reach and cost effectiveness of the intervention is always an important one. So will the intervention broadly cover our target population? So those are the types of things we looked at in terms of the postnatal classes. I'll throw it back to Mel to talk a little bit about the academic detailing.
All right, thanks, Steph. So we had modified the tool a little bit to make sure that our questions were a little bit more relevant to the topic of academic detailing. So in terms of political acceptability, we wanted to know whether this type of intervention or program would be supported within our current political climate, and whether it would be socially acceptable. So would clinicians actually be interested in this type of thing, or were they already completely, way too busy to be able to take time out of their day to visit with an academic detailer? We also want to know whether there were, to see if the staff had any perceptions in regards to ethical considerations of a public health unit delivering information directly to specific clinicians. We wanted to also address available resources, so kind of who would be the ones to deliver academic detailing? Did they have time? Were they trained? What type of training could we actually offer them? Basically asking staff whether this would kind of, fit with our existing human resources, or whether we'd have to, hire someone else, or kind of what would be needed for successful implementation. Also, we wanted to know whether this type of program would fit within our existing mission and vision and program plans within a bunch of different divisions, whether it's health promotion or clinical. We want to see if there were any barriers or structural issues or processes internally that would have to change, staff allocation, et cetera, and just basically whether staff perceived that the organization would be open to doing this type of program. For transferability, we wanted to know whether there was a need for this within our community. And with our catchment area, we have 19 municipalities, and we're pretty spread out. So, would it be essentially worth it, and how much would it cost actually to be able to travel to some of those further areas to deliver educational outreach visits? We also wanted to provide our staff with a summary of the findings from the rapid review, and to see whether they thought that it would be applicable within our current context, and whether they thought that our population of clinicians had similar needs, or they thought that issues, their own knowledge could be enhanced through this type of intervention.
I just wanted to throw in there, it's Shannon here, Jenny, for those of you online, that I think the key to the success for both of these A&T exercises was that not only we had the rapid review team at the A&T meeting and the programming staff that were directly involved, but I think the key to success was we had the management and we had the director of that division at the table. Because when we asked those hard decisions about, yes or no, who's going to be redeployed, is there emotional attachment to the programming, et cetera, if we didn't have the manager and the director at the table, then decisions couldn't have been made at that point. So I think that was the key for us.
That's a really great point, Shannon, and that kind of is a good segue into just a quick summary of what we felt were the benefits of using the tool. And just the consistency in allowing, it provided a method to keep the conversation focused and allowing everyone a chance to reflect on the questions being asked. It was also very nimble in terms of modifying the question to meet our local context, using the questions that were appropriate and applicable to the research question, which we really enjoyed in terms of its ability to focus the conversation. All important aspects were considered, and as Shannon mentioned, in terms of management and director buy-in, they have a lot of information with regards to budget pieces, political pieces that they could provide to the table that frontline staff may not be aware of, so it allowed a diversity of people there as well. And it was really practical, easy-to-use tool, and following the tool's use, we summarized the A&T discussion we had, and that was placed into the report to further refine our recommendations following the rapid review process. So just for sake of interest, in terms of our outcomes, for the postnatal classes, we did pilot the program again, and we piloted for approximately 6 months, and with a local Best Start hub, because that is a location that a lot of new parents tend to frequent. So, but unfortunately, just there was a lack of uptake within that time with that postnatal period. A lot of the mothers and parents tend to attend a little bit later in their infant's life. So we're still potentially looking at what it might look like in the future, and whether it would warrant looking at it again and possibly connecting with other health units in terms of what works best for them to increase enrollment.
Okay, and hi, it's Mel again. And for the outcomes of the academic detailing program, so afterwards we developed a clinician engagement committee that has representation from all of the different divisions and I believe teams within the health unit. And 3 public health nurses were trained in the fall of 2014 as academic detailers. We also started a list to try and collect and prioritize topics and, topics that could be considered for academic detailing. The program is currently under development. Within the next few months, the academic detailers will be piloting on low-risk alcohol drinking guidelines and a screening brief intervention referral. The pilot will be evaluated and the full program will be considered in 2016. So I believe that's pretty much it for us.
Yeah, that pretty much summarizes what the results of our rapid reviews, how they came about, and our use of the A&T tool. So we'll give it back to Jenny for any questions.
It's Donna, first of all. Thanks very much. I also wanted to let people know that we've heard from several different organizations that have adapted the tool. So several boards of education are using an adaptation of the tool for making decisions about curriculum changes and additional programming. Hospitals are using it for considering programming in hospitals, and if you find on the registry website, there's also an equity tool that Kelly Murphy at St. Mike's developed. So it's easy to adapt to different situations, and particularly you might be interested in the equity tool.
Great, thank you so much, Donna. And if everyone, you have any questions for any of our presenters, please take a moment to send us a question in the Q&A so that we can ask it of our presenters today, while giving people some time to generate some questions for our presenters. I just will address and make an apology on behalf of NCCMT. We recently updated the website and are still working out the kinks of our website update. And it appears that the A&T tool has succumbed to one of the kinks of our update of the website. So while the second link that I posted should take you to the tool in the chat section, you will be able to probably get to the full summary and what we were calling Part A, which is starting an intervention, but the link to Part B is not working. So what I will do is post all those links separately and a moment into the chat so that we might be able to, so you might be able to link to those actually directly. We're trying right now just to see if it's possible with our technology to share on the screen a picture of what the A&T tool is, but we're not sure that will work for us because it wasn't already embedded in the PowerPoint that you're seeing now. And so that was one of the questions from Natasha, which was, will we have a chance to see and discuss the tool in general, not only its application? So perhaps, Donna, you might be able to speak to a few other things related to maybe some of the sub-questions that are asked in the A&T tool, or ones that you might think come up most often or that health units struggle with in terms of some of the constructs under applicability and transferability?
Sure. I think there's always an issue with well, not always, with some of the implementations that you might be thinking about. There are issues about political acceptability. The first time I presented this tool to a group of medical officers of health, they said, we don't need any of these other questions. All we need is the political acceptability one. So you can see from their perspective, at the level they're operating at, that is a critical question for them. But there may also be some times when that's not such a critical question. Yeah, just hang on a second.
We're just going to put everyone on hold. If you please don't mind hanging on for just a few seconds, we will go ahead and try and share our screen so you can actually see the applicability and transferability tool. So just please hold on with us for one moment. So I think everyone should be able to actually see. I think we're able to successfully share our screen. So what you should be seeing now is the actual applicability and transferability tool. So I'll turn it back over to Donna.
Yeah, so from this screen, you can see that under applicability, there's the section about political acceptability with a number of prompts for the kinds of questions that get asked. Same with social acceptability, some about resources, and then the organizational expertise and capacity. So the questions to the right are not necessarily questions that you have to answer for every intervention that you're thinking about, but they are considered more prompts that will, in an organized way, get you to think through what the issues might be. Then the same with the transferability that you see. Do you know how to go down this screen?
Yeah. So let's see if it will. Sorry, we're just, again, doing some technical things.
So you can see there are three main aspects to transferability or generalizability. What is the magnitude of the health issue for you in your community? The magnitude of the reach. So can you expect the same kind of reach or an even better reach than is found in the research? And then what the costs will be and how the benefits might be related to the costs. And then the characteristics of your target population. So is it comparable to the study population, and are there differences in the characteristics? So any questions about the actual tool? The B tool about stopping the intervention came as a request from a health department where they said, yes, we can change the direction of these questions, but it would be easy if you would just produce one for us. So they're mainly just reversing what will be the social acceptability and partner organization acceptability if you stopped an intervention in your community.
Great. Thank you, Donna. And so for our colleagues at Sudbury and District Health Unit, we do have a question. From Rebecca. Did you experience any challenges in the process of adapting and using the tool? And if so, how did you work through them?
Hi, it's Melanie. I think in inviting a bunch of staff from a variety of different areas, and including managers and frontline staff and planners, we were able to address more of the questions that we asked. Should we have only done it with frontline staff? And I think there are certain questions that couldn't have been answered, as Shannon mentioned before, like things like, can we afford it? Or, what would have to change? Would it even be possible? Some frontline staff may have hesitated to talk about internal staff changes if there were no management present to be able to say, oh yeah, maybe, we could do that. So it wasn't, and it was 3 years ago, so that's pretty much what I remember. but it was more just thinking ahead of time who would need to be there to be able to answer the specific questions that we want to address, and do they have the capacity to provide an answer.
Yeah, I think Mel said it all. Like, I don't think it was that challenging because the tool itself is very clear, it's very concise, and we were able to get together as a research team and go through all of the questions and things to consider and whittle down what would be relevant for the program or topic area that we were looking into.
Can I just ask, when the 2 times that you used it, it's Donna, did you leave out any of the criteria or weight any of the criteria?
We didn't, I wouldn't say we weighted the criteria, Donna, but we did leave out some of the questions, some that maybe didn't pertain, or we maybe didn't feel we had time for, or if it was a question that was too political in nature, we kind of left those out. But we used, I would say, the vast majority of them.
Right, and my experience of people think at the beginning of a discussion that maybe 1 or 2 of the questions should be weighted, and I've had several experiences of the decision gets made to weight one of them, like community acceptability, for example, or costs, and then it ends up we weight every one of them, so it totally takes away the impact of weighting. So for the most part, I think you have the option of weighting 1 or 2 of the criteria, but people in the end tend to think that they are almost should be equally weighted.
Well, I think they should be equally weighted. I think, though, we go in there with the caveat that if the director at the table says financially it's a no-go, then that trumps everything else. I mean, that's my opinion, though. Mel?
No, all I was going to add is that, yeah, we didn't weigh any of them, but basically it was to ask as many questions as possible and get everything out on the table, so then those decision makers would be able to look at the pros and cons and what would be required to make a more informed decision.
Great, thank you very much. So we have another question for our colleagues at the Brain District Health Unit. And Leslie would like to know, this is a kind of process that requires good internal capacity. What kind of staff time did Sudbury have for both of these? To do the review, adapt the tool, and facilitate discussion/assessment.
Well, thanks for the question. That's not an easy one to answer. I wish we had protected time to do this, but I would say the honest answer is we don't. I think it's assumed in the role, particularly of the planner/health promoter, that they take this on. In my former role as specialist, it was assumed that I would ensure this was happening and I would lead these groups. So we do find the time, but I'll tell you that a rapid review that, you know, should take maybe 6 to 8 weeks took us 6 to 9 months because a lot of us did it off the side of our desk. So I wish it was protected time because I really value this work, but we're all so overwhelmed that we just try to find the time when we can.
And to add to that, as a health promoter, I guess my personal observation is that we do have the freedom to, I guess, sign on to some of these rapid reviews and to go through the process if we have a little bit more time available, and to kind of step back if we don't. We like to say that we don't wear hats, so we can kind of take off our programming area hats and be able to just work together as a member of the research team, regardless of which program area we come from. And so I guess that's the really nice thing, and those of us who have a stronger interest in research and in doing this have the opportunity to participate a little bit more, which is nice.
Yeah, it's definitely, and this comes out of a committee that we have. So when the questions are prioritized and they're brought forward, we do, like Mel said, expect people to volunteer. There are certain program areas that tend to volunteer first, and then we hope to get a few program staff involved as well because they have a lot of hands-on experience with a lot of these, and it affects their programming area. So as Shannon and Melanie both said, it is kind of off the side of our desk, but depending on what the program is, depending on what the priority is at the time, we can make it a little bit more of a priority depending on what topic is coming out, whether it's an accountability indicator. Those are all things that we would consider.
And it's Donna, I could just add a bit to Leslie's question that there are a few publications about the process of rapid review, which can be very different depending on the topic, and the key issue is to be transparent in what shortcuts you've taken to make it a rapid review. My experience of once the rapid review is done, it's really only an hour-and-a-half discussion of people who have thought about the questions in advance to get to some consensus about whether or not they're going to go ahead. So the actual applicability and transferability discussion only took an hour-and-a-half to 2 hours to get to some consensus about going ahead and recommending the implementation or the de-implementation, or recommending no, not to implement or not to de-implement.
Great, thank you, Donna. So thank you also to everyone who's posting great questions in the chat and the Q&A. It's great that we have a lot of time, so we're going to continue on. And again, I encourage people to continue posting some questions for our presenters. So I'll pose this question to Donna. How would you consider applying an equity lens to this tool? Can we use the Equity A&T tool instead?
Yes, I think the answer is yes, you can use the Equity A&T tool for most implementation and probably most de-implementation. So you'll see that the adaptation that Kelly Murphy did to the Applicability and Transferability Tools is to build in the equity aspect. So sure, that would be great to use that one.
Great, thank you so much, Donna. And so I'm just making sure we get to the next question here. And so I did see, yeah, so this is another great question from Leslie. So in the Sudbury District and Health examples, did any or either include any external stakeholders in the discussion/decision-making conversation? For example, Head Start. And if there were only internal stakeholders, what was the thinking behind this decision?
So this is Stephanie from Sudbury. No, we didn't have any external partners at the table per se, but we did, following the A&T tool and a summary of the recommendations, we did approach partners who were working in the same area to further refine our decision-making in terms of what program we were looking at.
Yeah, and I think part of our data collection and our evidence gathering in the rapid review itself was doing a bit of a situational assessment. We sort of went out there and did a quick survey of what was happening in the community with Best Start and OCOF and BBBF, and so we had those in our rapid review summary that we provided to the people at the A&T table. But no external people were explicitly invited, no.
Great, thank you so much. And I will quickly reply to Sharada's question about that. This looks great. Is there an automated version of this tool? And unfortunately, there is not one at this current time, but that is a really great suggestion. So we will certainly consider that if we can have the resources and the time to do that. So thank you so much for that suggestion. And we have another question for Donna. So Donna, how much of this tool is in connection with the intervention evaluation and some other frameworks, for example, the RE-AIM framework?
Yeah, I think it does fit in the process. I mean, if you follow the steps of the wheel, it's really an expanded problem-solving process. So I would see the intervention evaluation being part of the definition of the problem. So, for example, if you have evaluated an intervention, you're not getting the kinds of results that you expected to get. You might think, why is that, and is it the intervention isn't working with this population? So the evaluation might lead you to this question that would take you to the literature and get you into the wheel in that way. The other place where it comes in would be at the end of that problem-solving process. So you have gone through the A&T tool, you made a decision to implement or de-implement, and then it would require some evaluation, the evaluation of the implementation or the evaluation of the de-implementation. So I think it fits well in terms of any of those other frameworks that you might think about, but as a way of defining the problem or as a way of evaluating the results of the decisions that you make at the A&T level.
Great, thank you so much, Donna. So we did have one of our participants actually provides a suggestion here, and so thank you to Elizabeth. She said when facilitating the A&T tool at a meeting, which included community partners, she used the EIVM fact sheet to orient people to the process, and then linked it with the colored bubbles or circles, going back to Donna's presentation, our model for evidence-informed decision-making, to the relative sections of the A&T questions. So that's really great. Thank you so much, Elizabeth, for that suggestion. While we wait to see if there's any more actual questions that anyone has, so please continue to go ahead and let us know if you have any other questions. We'll just open this next polling question here to find out about what your next steps are. So would you plan to access the tool? I know we're having a bit of issues with some of these. Read the summary. Would you actually consider using the tool? Or would you tell a colleague about the A&T tool? So please go ahead. You can actually select any that applies. So it'd be great if you could let us know what your next plans are for today. So just, I will continue to keep an eye here to see if any further questions come in, and not seeing any questions at the moment, but again, we have a few more moments for sure, so we'll give that some time. So most people, we're getting a range of responses to this polling question, so thank you very much. Seems that everyone's sort of planning on doing a bunch of different things, so that's really, really wonderful. Thank you so much. And so, again, we're continuing to take your comments and questions. And as always, your feedback is important to us. And so we would ask you to take a few minutes. I will go ahead and post the link directly to our evaluation survey. So if you wouldn't mind taking a few minutes following today's webinar to go ahead and evaluate us on what we can do better. And preparing for future webinars, it would be much appreciated. So I will go ahead and post that link in the chat box for everybody to click on, hopefully. And just again, I'll do another check of the questions to see if anything has come through. And yeah, so no further questions in the chat or the Q&A, so please go ahead and post any before we actually close the webinar today. One of the things that we would like to bring your attention to and ask that you might consider participating in is a study that here with the supportive health evidence, myself and Dr. Maureen Dobbins, the current scientific director for health evidence, and NCCMT are conducting. And we are inviting those working in cancer prevention, so whether it be in areas of physical activity, tobacco use, nutrition, and are interested in using high-quality research evidence, so systematic reviews that are very well done to support their work in planning programs and policies, that we would actually invite you to participate, and you can choose one of 3 methods, so Twitter or tailored messages or webinars like today to receive information about cancer prevention. So again, I will go ahead and post a link to that should you care to participate or check it out. And so that would be really great. And please feel free to go ahead and pass on to anyone that you know within your health unit or other health units that might be interested in cancer prevention research evidence. So I'm looking through again, and I will thank all of our presenters and your time, all of the attendees. I'm not seeing any further questions or comments come into the Q&A. I will turn it over first to Donna and then to our colleagues at Sudbury and District Health Units to see if they have any last thoughts or comments or questions or even questions for each other with a few moments left. So Donna, I'll turn it over to you.
Yeah, it's Donna. I just have one comment that I just got an email from our webmaster saying they're in the process of fixing the broken link. So apologies that we didn't check those out beforehand.
Thank you. And Donna, any last minute words of wisdom or anything you'd like to leave the audience with today?
No, I think my experience of this is just that people find it a structured tool to help them go through pieces of information that they probably would have thought of, but they might have missed some. So it's just a way of adding a bit more structure to decisions. And maybe one last thing. Of course, I started out saying I have nothing to add. One last thing is that when you are considering a number of different interventions, people have used the scoring as a way of setting priorities across those 4 or 5 new interventions. Thanks.
Great. Thank you, Donna. And our colleagues at Sudbury and District Health Unit, any last words of wisdom or golden nuggets or advice to add to our attendees today?
I would just say that we've really enjoyed using the tool. We find it very effective. In fact, we've made it part of our new planning cycle to make decisions and priority set in everything we do. So we really enjoy the tool and use it anytime we can. So that's our plug.
Great, thank you so much. So thank you again to everyone who has joined us today. We will be holding some more webinars within the Spotlight series come the new year. So late January we're planning, we don't have the date set, but we're hoping to provide you with a tool on checklist that you can use within your health units for evidence-informed decision-making, and further tools in our series February through June. So please join us again in the new year, and please keep following us at NCCMT for more information on how we can help support you in achieving EIDM, evidence-informed decision-making in public health. So thank you to all of you who joined today, and from NCCMT, have a happy holiday.